welcome everyone to another video. It's a nice and sunny day here in northeast Victoria. It would have been a perfect day for some bushwalking or some mountain biking, but here we are. Okay, today we're talking about VTE prophylaxis in acute stroke. This is a continuation to the last video on VTE prophylaxis in general medical patients. Today we're focusing on acute stroke patients. So if you have a big stroke, that usually means reduced mobility, and that puts patients at high risk of DVTs and PEs. So the risk is estimated to be around 2 to 10%, and PE is one of the most common causes of death following stroke. So what are the recommendations? So mobilize early. So get the physiotherapist involved and maintain adequate hydration. If a patient with ischemic stroke has reduced mobility, make sure that they're started on VTE prophylaxis, and this is usually done on the day of admission. This is unless the patient have gotten thrombolysis. In that case, you withhold aspirin and VTE prophylaxis for 24 hours. We'll come back to that one. The heparinoids, things like clexane or deltaparin, are not recommended in hemorrhagic strokes. So the key is to use mechanical prophylaxis, so intermittent pneumatic compressions, sometimes called sequential compression devices, are the mainstay in hemorrhagic strokes. VTE prophylaxis with clexane or other agents may be considered after 48 hours, but usually the physicians or the neurology team would be very reluctant to do this. They usually do a scan, and if the bleeding area is not getting any bigger, then maybe there may be some consideration to start them on VTE prophylaxis, but this is usually on the discretion of the neurology team. The last thing I want to add on this page is this finding by the Cochrane Review in 2013, which reported that stroke units tended to do much better for all patients with stroke compared to the general medical ward. So if you have trained staff and there's motivation to get better, people will do better. Alright, so let's move on to the next section. Okay, so I know this looks busy, but we'll just try and break everything down, and we'll take it slowly. So if I have VTE risk level here, and we have low risk and high risk patients, and we've got prophylaxis here and duration in this row. So with patients with low VTE risk, so anyone with a Padua score of less than 4, if you don't know what that is, then make sure you check out my previous video. These patients who are deemed low risk usually don't need any VTE prophylaxis. And the key here is to mobilize them early and maintain adequate hydration. To this column, I would also add patients who are started on dual antiplatelets for a minor stroke or TIA. So this is usually aspirin and clopidogrel is usually done for 3 weeks. So these are patients with the NIHSS of less than 3. So it's reasonable to continue to put them on DAPT and not start them on VTE prophylaxis. So remember, this was from the CHANCE trial and the subsequent POINT trial, which was the CHANCE trial was done earlier in China, in the Chinese population, which showed that using dual antiplatelets for patients with minor stroke or TIA in the short term was beneficial. So what about high-risk patients? So anyone with a Padua score of bigger or equal to 4. And this includes patients with a stroke and reduced mobility. With hemorrhagic strokes, obviously low molecular weight heparins are contraindicated, so no pharmacoprophylaxis for these patients. Key is to use intermittent pneumatic compressions started on admission. And maybe later, if the bleeding is reversed, there may be consideration to put them on VTE prophylaxis. The use of graduate stocking compressions, or this is the same as your flight socks, is not recommended in either of the high-risk patients with a stroke, because studies have shown that this has no benefit and might actually do some harm. So do not use graduate stocking compressions. With patients with ischemic stroke, it's recommended to use IPCs again on admission, and also consider low molecular weight heparins. So enoxaparin subcut 40 daily, or dalteparin subcut 5,000 units a day for ischemic stroke patients with a high risk of VTEs. So how long do we use this for? So with mechanical prophylaxis, it's usually until the patient is mobile, or mobilization to an acceptable level, or until discharge. There's the same principle for heparinoids in ischemic stroke. So use the Clexane until patient is mobilizing to the anticipated level, or until discharge, whichever one is sooner. The other thing that I want to mention is patients who are thrombolized. The thrombolysis on admission using alteplase or tenecteplase, VTE prophylaxis should be withheld for 24 hours. So don't start VTE prophylaxis within 24 hours of thrombolysis, and same goes with antiplatelets. So no aspirin or VTE prophylaxis after thrombolysis, after 24 hours after thrombolysis. The other thing that I would like to mention is thrombolysis places patients at risk of hemorrhagic transformation. So hemorrhagic transformation of ischemic stroke is a complication, and it's quite severe. So the decision to start patients on VTE prophylaxis following thrombolysis should be at the discretion of the treating physician or neurologist. All right. The last points that I would like to add is patients who are already... Oops, sorry, give me 1 second. I'm just trying to work this technology. Okay. So what about patients who are already on anticoagulation when they are admitted to the hospital? If they're continued on their full dose anticoagulation, then they obviously don't need any VTE prophylaxis. But what usually happens is that the full dose anticoagulation is withheld because of this risk of hemorrhagic transformation of the ischemic stroke. So in the interim, while the full dose anticoagulation is being withheld, patients can be considered for VTE prophylaxis if they're high risk, and if there's no contraindications to using Clexane or things of that nature. The other sort of population that you come across in the general medical ward is patients with newly diagnosed atrial fibrillation following a stroke. So what's the best time to start them on anticoagulation? And this is not known, so we don't know what the best time is. The Stroke Foundation guidelines recommend the timing based on stroke severity. So if it's a minor stroke and a patient is diagnosed with atrial fibrillation and there's a CHA2DS2-VASc score of bigger than 1 or bigger, if it's a minor stroke, then we can start them immediately. If it's a moderate stroke, then that's and full dose anticoagulation has to be started after 5 days because of this risk of hemorrhagic transformation. And if it's a severe or large stroke, then wait 10 days before starting anticoagulation. In the interim, while the patients are waiting to be started on full dose anticoagulation, patients can be put onto antiplatelets and can be considered for VTE prophylaxis. Alright, that brings me to the end of this discussion. Thank you for watching, and have a good day.